Hi.
Excellent. Hi, everyone. Right. Welcome to the ITP Sport Association virtual meeting for England and Wales, the first meeting of 2025. And as it's the first time I've met most of you, Happy New Year to you all. I'm sure I'm allowed to say that still. This meeting is being recorded, just so we can put it up on our YouTube channel afterwards, because lots of people like to watch them back, especially half the people who actually attend the meeting always like to review it and see, just update themselves on the answers to some of the questions. Got a few people with us tonight. Firstly, I'd like to introduce our clinical expert, Professor Adrian Newland. Adrian, just put your hand up.
Hello.
Hi, mate. And we've also got some board members here. Anthony, who's our latest, newest trustee, and Rhonda, who's with us as well, our senior mentor, and then two other mentors that we've got, the lovely Karen from down in the West Country and Diane.
Hello.
Hi, everyone. My name's Mervyn Morgan. I work for the ITP Sport Association. Please be free, happy to ask any questions you like about ITP. If you do want to ask a question, there is a react button down the bottom. You can just raise a hand, or if necessary, just put your hand up, and I will try and see who's next in line for the questions. So, has anyone got a question they'd like to open with? Marvad, first. Just got to unmute.
I just wanted to ask about Avatrombopag because I was put on steroids and we had to stop them because the sugar was shooting up. So they're going to put me on is it Avatrombopag? But it has
Avatrombopag.
Yeah. So it has so many side effects. What are the choices there apart from that medicine?
Well, if you look at the inserts for any medicine, you'll find lists and lists of side effects because from the legal point of view, the companies have to include everything that a drug may be associated with, whether it's a strong association or very, very unlikely. I mean, I must say that apart from the obvious risk with Avatrombopag of the platelet count going high and leading to clotting, it's actually really pretty well tolerated by the majority of people who have it. And it's certainly not something that you should avoid for the potential risks of what may happen. I mean, certainly you've had problems with steroids, and steroids is probably one of the most toxic drugs that we have.
True.
And all the other options, I know for one of them, azathioprine, which some of you may have come across, Imuran, if you look through the side effects, it says one of the side effects is thrombocytopenia. And many patients with ITP, you hand it to them, they come back and say, but it causes thrombocytopenia. Why are you giving this to me? And that's because in normal people where it's given for other conditions, if the bone marrow gets suppressed, the platelet count will fall. But of course, we don't give that amount of drug to people with ITP. So the companies have to cover themselves because they know they'll get sued if there's something that happens 1 in 10,000 times and it happens to happen and they haven't mentioned it. So what I would say is that Avatrombopag is actually a really pretty well tolerated drug. I mean, everyone can have some effects with anything. And a lot of people do have problems if they may complain about tiredness or whatever, but you can never be certain if that's related to the ITP or due to something else. So what I would say is from anyone offered these drugs, the doctor who offers them to you should talk about any potential side effects that they're likely to cause. And then it's worth trying them for a trial period and seeing how it affects you, because you're the one who's getting it. You're not, the population as a whole isn't representative of an individual person. The side effects are a cumulative response to what everyone's had. So I wouldn't be put off by what you read in the leaflet, which is very, very comprehensive. And if you read them all, very frightening.
Yeah.
Okay, thanks very much. We've got loads of questions. The first one to put his hand up was Bill.
Okay, a couple of questions about Avatrombopag. I just wanted to clarify what its status was as far as NICE was concerned, what conditions it can be prescribed for, and its benefits over the L-Trombopag. I understand that you don't have to have no dietary restrictions
Yes.
with Trombopag. That's the big advantages. So
Yes.
am I right there?
Yes. It's recognised by NICE in ITP, and it's unlike the other thrombopoietic agents. It's used when first-line treatment has failed, which most of us now can interpret and get away with steroids, because it is quite a potentially very good second line in terms of long-term effects. It's been tried in a number of conditions, as have the others, L-Trombopag and Romiplastin, in patients with thrombocytopenia who had chemotherapy or a variety of other conditions. It's in general pretty similar to L-Trombopag, but the advantage is, as you've stated, that issue of dietary restriction, which many patients find really irksome. And so, although NICE have agreed it, some commissioners are reluctant to pay for it, and you may have to have L-Trombopag if that's what's offered. But Avatrombopag does have advantages. You don't have to worry about when you've had a glass of milk or whatever.
Okay.
Okay.
And you had you had something else.
Bill?
Sorry?
You
There's one other
said
question.
you had another question. Yeah.
Yes.
Well, it was merely a question of I wanted to know about a nice definition of primary ITP, because that seems to be the condition that you have primary ITP, i.e. ITP with no clear reason or diagnosis or underlying diagnosis, should we say? Is that the case?
Yes, although in the definition of what's a clear related condition is quite a difficult one. And in fact, it's something we've been debating amongst ourselves at the moment, because you may or may not know that we've started off a registry of patients with secondary ITP, and we're having real debates as to what is secondary ITP, because many patients with ITP have associated immune conditions, and arthritis, lupus, but some different things like thyroid disease, or because autoimmune diseases tend to accumulate because they're vaguely all related. So if you take a drug and 3 weeks later the count falls, then you know it's related to the drug. But many times you cannot be absolutely certain what a causative condition is. And to be honest, it depends very much on how smart your doctor is in how he describes your condition. Because obviously most of us want to give effective drugs that are as free of side effects as possible. And Avatrombopag certainly falls into that category, as did L-Trombopag, despite the dietary problems, or Romiplastin, despite the fact that it has to be injected. And I guess the last time I looked at it, the use of the Romiplastin and the tablets was about 50-50 in the UK. And some patients actually prefer just have one injection once a week and forget about it, rather than being tied to daily tablets. So the answer to your question is yes, NICE does do it in primary ITP. Primary ITP is a loose definition. It's in general no obvious other conditions. In most adults, it's unusual to find an obvious associated condition.
Okay.
Thank you very much, Bill. Right, next question. Lauren, your hand was up next.
Thanks, Mervyn. So continuing with Avatrombopag, I was wondering what your thoughts are on discontinuing in the hope of sustaining remission level, or stability at least above 50.
That's a very interesting question, and the real answer is we don't know, because Avatrombopag hasn't been given long enough to be able to make those observations. I have to say my general feeling is I don't see why it should be any different from the results we've seen with Romiplastin or L-Trombopag, because it's not the drug that causes the sustained response off treatment. It's the platelet response itself. It's sort of, I won't go into the details, but it's probably related to the impact on the immunity of being exposed to high levels of platelet antigen that suppresses immunity. And I would think that Avatrombopag is almost certainly likely to cause that. And I think anyone who has a sustained high count, and by that I mean over 50 for a period of time, I mean, we chose 6 months, whether that's the right time or not, we actually don't know, should actually have a trial of tailing it off, because if the count comes down, you can restart. When we did the original work on Romiplastin, we were planning to stop at 6 months, tail it down at 6 months. But for patients earlier than that who had higher counts, and we were reluctant to give the tolerated dose on a weekly basis, and we're beginning to either reduce the dose or increase the intervals. Some patients were having sustained responses at 2 to 3 months. So it's related to each individual's response. But the answer is I would be extremely surprised if Avatrombopag didn't show the same sort of response, which is a sustained response off treatment in probably around 30%. And carry on. Yeah.
Sorry, I was just going to ask, do you think there's any increased risk if you attempt discontinuation and it doesn't work, so you crash, you go below 50, then restart treatment? Is there any increased risk in the treatment not working then and not responding to it after?
There's no reason why the response shouldn't be repeated. I mean, I must say that if we were tailing it, you want to still check the platelet count regularly. What we don't want to see is the platelet, as you said, crash. If it drifts down, you know, if you're running above 50 and it drifts down and is hitting 30, I would then restart. What we don't want to see is it going from 50 to less than 10 in a fortnight, because that's associated with increased bleeding risk. It's as much the rate of fall as the level of count that's associated with the bleeding risk. But again, there's no reason why the response shouldn't be repeated, because the conditions are exactly the same. You will sometimes lose the response to one of the thrombopoietic agents after several months. You sometimes see, despite the continuing dose, the count starts to drift down, and then you may see a response if you change onto one of the other agents. We certainly see that in a significant proportion of patients. But coming back to Bill's question, what we found with Eltrombopag is that the commonest reason for patients failing Eltrombopag was they became lax in their dietary restriction, that they got complacent because the count was stable and they were fine, and you'd begin to forget, and occasionally you'd lapse and take the wrong thing. And so in someone on Eltrombopag who's beginning to fail, the first thing you do is go into their dietary history in some detail just to check that they're doing it before you swap.
Thank you.
Okay, thank you, Lauren. Right, Jacob, you was next.
Yes, hi, thank you very much. I've gone through Eltrombopag, which didn't work for me, and I had to move to Romiplastin, which I've been on it for, I think, close to a year. I personally enjoyed it very much. The restrictions are not there, and I found the ability of taking it only once a week is very beneficial. It's a bit difficult when you're traveling and taking it through security in airports.
Yes.
With ice packs, but it's something that I could live with. My main question is, I mean, until I was diagnosed about just a year and a half ago with ITP, I've been a healthy person. At the moment, it's not really affecting my life. But what dangers are there from taking Romiplastin long term?
In general, it's easy to say nothing, in that people do take it long term. Some people have taken it for many years with a continuing response. Now, there's the risk of actually just losing effect and the count beginning to drift down. Some of these agents do cause what we call fibrosis in the bone marrow. that it's a sort of response to having increased numbers of the megakaryocytes, which are the sort of mothership that produce the platelets. They produce factors that can cause fibrosis in the marrow, and that can affect how the marrow works. But you can see that on the blood count. It has an impact on the blood count, and if you then stop the drug, it reverses completely. Now that happens with any of the three agents, Rituximab, Avatrombopag, and probably Avatrombopag as well. Although again, we haven't been using it long enough to know that. But in general, if you're fine and you're responding, then it's reasonable to go on with it. I mean, I talked with Lauren about whether you can reduce the dose. In general, if the count is maintaining quite easily or creeping up, or the intervals between injections are being able to be increased because of the response, that's when you look at responding. But if it appears that you need the weekly injection to maintain your response, then we're often quite reluctant to do a trial off treatment.
I was never offered. I mean, the last twice, I think my numbers were 120.
Yeah.
I was never offered to try and take down the dose or maybe increase the intervals.
Yeah, it depends, I guess, on your clinician's experience with ITP, these agents, and how involved they are in the ITP treatment community. Most people who are involved with ITP in a big way would understand those issues and would probably consider whether to give a break on it. And by giving a break, we'd probably initially start off by saying, if instead of getting it weekly, you get it fortnightly at the same dose. And then, I mean, that was how we initially learnt of this issue of sustained responses, that patients were having good responses when they came back for the weekly treatment. So we said, look, come back next week, and you do it next week. Some were going up for 3 weeks, and then we thought, well, let's just reduce the dose a bit. And a little bit, you thought, well, are these small doses every 3 weeks actually in any way effective? Let's stop them and see what happens. And that was how we actually found out you could get long-term responses off treatment.
Okay, thank you.
I mean, yes, I would say that you do see long-term response off treatment with many other drugs as well. I mean, we saw it with intravenous immunoglobulin in the 80s. So this isn't a new phenomenon. If someone's count is high enough, long enough on whatever treatment, they may well achieve some sort of immunological tolerance and have a sustained response.
Thank you very much.
Okay, thank you, Jacob.
Thanks, Jacob.
Right, there's a new chap, Lewis. Welcome, my friend. I don't think we've seen you on here before.
No, yeah, hi. So I was diagnosed last summer. It's interesting to say, actually, because we were talking about other autoimmune conditions. I have psoriasis. I have done since I was about 10, and that's how this was discovered, through sort of blood work for my psoriasis treatment. I've stayed pretty consistent on sort of the low 50s. I have had a few dips slightly below. I have gone slightly higher, but I've not had any bleeding or any symptoms. So I've not had any treatment. So my question is more about sort of being able to do things, specifically being able to fly, I suppose, the safety of it. And if I am in sort of the low 50s or high 40s, should I be having some sort of treatment to sort of get that platelet count up before attempting to fly?
No, in general, if you're running counts of 50s, and even if it dips down slightly into the 40s, you're almost certainly at no risk from flying, particularly in modern aircraft. The pressures don't fluctuate that much. And the potential effects to you of, say, taking a dose of steroids to boost the count before flying are probably greater than actually running a count of 40 or 50. And I think just watching and waiting or intelligent observation is exactly the right way to treat it. Well, what treatment do you receive for your psoriasis?
So I used to be on cyclosporin. And the funny thing was that I got taken off cyclosporin because they wondered if that was causing some thrombocytopenia. I was around the 70s then for a few times of blood tests. They took me off it. I was about to go on holiday the next day. We couldn't go because suddenly my platelets had dropped to 50, and they were like, oh, how have you suddenly dropped? And it was actually, obviously, the cyclosporin was probably helping keep that platelet count up. I'm now on Rituximab biologics, which is doing really well for the psoriasis. After the first dose, I jumped up to 100. Then I went down to 70, back down to 50. Last week, I was around 60. So I think possibly the first time it went in, it might have done something. But for now, it's back to sort of my normal,
Yes, I mean, interesting enough, we used to use cyclosporin and still do in very difficult cases to treat ITP, as you've probably seen. So it may well have had that little kick in your counts. And the other agents for psoriasis may be associated with an improvement as well. So yeah, it's entirely right just to keep an eye on it, because we always say don't necessarily go on your count, go on your symptoms. So if you suddenly get lots of blood spots, then that's when you think, I better have the count checked and think about this, rather than say, oh, the count's low, we've got to give some treatment. But running 40, 50, 60, I would be quite comfortable with that.
Okay, thank you.
Can I just make a comment for Lewis there? Several years ago, Lewis, when I was still at work, I flew quite regularly, and in those days, my platelet count was just between 20 and 30. And I didn't have any problems. The only thing was I didn't have any bruising. I was quite stable for a long time at that level. So I was okay to fly. It's just that the insurers needed to know about it. That was all.
Of course.
Made them a bit, whatever. But anyway, all the best. Enjoy your holidays wherever you want to.
Thank you, Karen. Thank you, Lewis.
I mean, just coming back to a count of 50 or 60 is pretty good for everything except possibly major surgery.
Right.
When you want to see it going up over sort of 70, 80, and that it's you're having treatment but even for minor surgery, I mean, dental surgery, you may have that, or minor biopsies and things. No problem at all with a count to that level, although sometimes the surgeons get a bit panicky and have their hand held a little bit. But it's only if you have something major would you want to have some treatment just to push the count up. And what we would tend to do now is give you a couple of weeks of probably Avatrombopag. It used to be Avatrombopag, but we'd now probably give you Ava, just because we don't have to worry about diets and things.
Right. Yeah.
Okay.
Thanks.
Thank you very much. Right, Stephen, you've had your hand up for ages. It's Stephen Bonney, and then the lady with iPad 2, I think. So yeah.
Right. I just want. This is the first time I've attended one of these online meetings, so very grateful for that. So thank you, everybody. My question really relates to exercise, not in terms of bleeding or bruising type risk, but more in terms of platelet production and elimination. So all my adult life, I've exercised quite heavily. And I understand obviously that moderate exercise is pretty much good for everyone who can do it. We could call my level of exercise immoderate. I've had a couple of periods of enforced inactivity, during which time I've noticed my platelet counts actually go up when I'm not exercising. So usually I languish in the 40s, but they may increase into the 60s when I've had a few weeks off exercise. So it started me thinking, well, firstly, I was thinking, is it I'm stressing my autoimmune system, then that's sort of kicking into overdrive, and then that's killing off the platelets. But then I was reading a journal article recently in physiology around normal populations, and that vigorous or excessive exercise can decrease platelets as well. So I was wondering, is there an understanding of whether or not one should be doing fairly excessive exercise, I guess?
I think there are two answers to that. One, I don't think the data is there on excessive exercise. Minor exercise that brings the heartbeat up may actually be associated with a slight increase. And it's in many ways a little bit artificial, in that by increasing blood flow, you get increased blood flow through the bone marrow, and there's a pool of platelets that sit in the marrow. So essentially it's flushing platelets that are there anyway. So that's one of the reasons why when you cut yourself, you may not bleed to any great extent, or you'll bleed for a little bit longer, but it stops because you do have that reserve. And funny enough, I was discussing this earlier in the week about something totally different, that if you have a severe accident, I mean, if you break a leg or get hit by something or have a severe infection, the platelet count will often go up purely because there's that reserve there. It's part of the body's defense mechanism. You have that reserve that can suddenly flood out. Now, I could see that if you're exercising excessively with increasing blood flow, we know that the platelets are removed in the spleen, in some people in the liver in chronic ITP, some people in the lungs, because the lungs have a lot of these sort of defense mechanisms because they help you fight infection from anything you breathe in. And it may be that increasing the blood flow through those may actually enhance the opportunity for the platelets to be removed from the circulation a bit more easily. I mean, I say that with that's speculation. I wouldn't say this is absolutely what happens, but it's a realistic sort of physiological mechanism to suggest that may be a problem. I mean, I've always said to patients, and we've tried it once or twice, that someone's platelet count is running lowish and they get worried because it's down 5. I say, look, go and walk up and down stairs 4 or 5 times and we'll take another blood count. And you take another blood count, it's gone up. Now, that may just be the routine fluctuation we see during the day anyway, or it may be related. And I just felt this was always due related to platelets being released a bit more easily into the circulation. So the basic answer is, Stephen, I can't tell you, but and it could go either way. But I think it's, again, if you've seen it going down when you exercise hard, as long as it's going to levels that are still safe, if it's not going below 40, if it's not going below 30, then there's nothing really to worry about. I mean, okay. There's certain forms of exercise that I've rather argued against, like particularly weightlifting. And extreme weightlifting, I don't mean the sort of thing where you're using a couple of 5-kilo dumbbells or 10 just to strengthen your back or your biceps or whatever, but the really heavy duty stuff. It's the sort of exercise that increases intracerebral pressure, because that can, if there's a very low count, it can cause cerebral bleeding. But I'm talking about counts of less than 20, less than 15 at that sort of level. At counts of 30 plus, that's probably not an issue. But I do worry about that sort of extreme exercise that can put up your intracerebral pressure, because you're developing more, becoming hypertensive just with the stress of the effort.
But I guess at that point you'd be symptomatic in other ways, wouldn't you? So
sure.
No, not doing that kind of.
But running long distances or cycling hard or whatever you do, that's not really an issue, provided you're running counts that are safe.
Brilliant. Music to my ears. Thank you.
Okay, thank you, Stephen. Right, it's Bonnie next and then iPad 2. So Bonnie.
Hello.
Hello there.
Hello. I've had ITP for 9 years, and for the first 7 years it was a nightmare. I was generally below about 30, tried all the different drugs, I was all over the place. And then in the last 2 years, I had my estrogen tested. I'm 45 and my estrogen was really low. So they put me on HRT, a really low dose of estrogen. My estrogen's gone up really well. I feel really good. My platelets are now in the 200,000s. So there's 2 questions. One is there a relationship between hormone imbalances and the effect on your platelet count? And secondly, should I start? I'm on 75 milligrams of Avatrombopag. I have been for the last sort of 6 years. I've been Romiplostin, I've been Rituximab, I've been steroids, I've been everything. And Avatrombopag has been the most sustained effect. But firstly, is there a relationship between hormone imbalance, or do we know anecdotally? And secondly, now that I've finally got to 200, I want to stay here and not taper, but I do appreciate that I probably should be thinking about tapering, or maybe not, and how do I do it? Because I've tapered before when I shot to 409,000 because I had a gastric flu, and then I went down to 50 milligrams a day, and by 2 weeks I was under 50,000.
Yeah.
So, yeah.
I mean, the issue is really, is your platelet response due to the HRT or due to the long-term effects of Avatrombopag? Yeah. And it's difficult to tease them. There certainly are hormone influences in ITP. I mean, ITP is more common in women, and it's more common in middle-aged women, and that's
interesting.
And that's related to the hormones. Over 60, it's more common in older men because of their immunological function is not as good as women's in the over 60s. But we see there's more autoimmune disease in when I say middle-aged women, I don't really mean middle-aged. I mean sort of 20 to mid 50s, and that's almost certainly related to hormones. Now, whether that's related to imbalance, estrogen levels, we don't really know, to be honest. It's like many of these things, but certainly we don't see a regular association with hormone replacement therapy and platelet responses. There could be, we just don't know, because it's the sort of subtle changes in hormone. We just don't have that data. My general feeling is, if you've been running counts at over 200 for a while, whatever for a while is, and you feel comfortable, and for a while, I think a minimum of 6 months.
Okay.
I would look at trying to reduce a little bit. So maybe going to sort of 75, 50 on alternate days. Do that 75, 50, 75, 50. And if your count stays up there for 2 or 3 weeks, drop down to 50.
Yeah.
And if it stays like that for 2 or 3, 4 weeks, drop down to say 50, 25. So do it gradually like that.
Yeah.
So it's suddenly removing the stimulus overnight as where the problems arise. It's not tapering it.
Absolutely.
And also,
in the past, when I went to 409,000, we were all slightly horrified. I think the reaction was just get down to 50 and we don't really care if you crash. Not in a bad way, just the 409 is way too much. So every time I've, in my eyes, reduced things, it's always been a really heavy-handed reduction. And it needs to be subtle.
I mean, coming back to the point that Lauren made earlier, what I don't like to see is the platelets crashing. I like to do whatever it can do to see the count slowly drifting rather than removing everything and just saying, well, let's see what happens. Because often you know what's going to happen.
Absolutely.
You don't always. So I like to reduce the stimulus in a very slow way. And I may be a trifle more cautious than many at that, but I prefer caution to excitement.
Yeah, that's really helpful. Thank you.
Okay. Thank you very much, Bonnie. Right, the lady iPad 2, the lady with the glasses and the pearls. You're muted there. You're muted. At the bottom left-hand side, it says,
can you hear me now? Okay.
Yes, you can. Go ahead.
Thank you. I maybe should say first that I had a brain bleed which affected my speech. So please, can you bear with me, because sometimes I break down a bit. Anyway, I have had ITP for, that I know for 4 years, probably a lot before that. On November 4th, I went into hospital for a hip replacement, and 5 minutes before I going to go in for the operation, the anaesthetist came and said, I think I need a blood test. And my platelets had gone to 63. This, for me, this is not a bad level at all. But my consultant has said I needed 70 for the operation. So because of my brain operation and a seizure, they not want to give me a general. And now, because my platelets had gone low, now they send me home. And now I'm hobbling around with bad hip. I must return in spring to reassess. I have done reading about, they were going to give me a spinal block for the operation. And the anaesthetist said he very worried about this and about the possibility of having a hematoma where the tube it put in for the spinal block. So I just want to know what my position is, how you feel about this. Should I have, for example, steroids beforehand for make sure the platelets go up? Or
are you receiving any receiving any treatment at the moment?
No, nothing except I have to take, this was a little problem. I am on something to stop the seizures coming back called levetiracetam. It's an anti-seizure medication. So that, but nothing for the ITP at the moment. In the past, yes.
I mean, what I would say in general, there's no difference in bleeding between 65 and 70. The counts aren't that accurate. The machines aren't that accurate in doing the measurements.
Right.
What's good at 70 is equally good at 65. If it's 50, then it may be a little bit worse. But in general, a count of 65, 70, 75 would be fine for hip replacement, although we'd often use a drug called tranexamic acid that reduces local bleeding. It's not a treatment of ITP, it just reduces bleeding. But I would say that most anaesthetists would be reluctant to do any intervention around the spine with a count much less than 75, 80. Just because of that issue of getting, for those who, hematoma is essentially a bit of, is like a bruise collected in a single area. So it's a collection of blood. And so they're worried that if they put a needle in and there's a bit of oozing around there, that may just press on either the spinal cord, which is less likely, or the nerves around there. It depends. I mean, obviously, I can't give advice on medical treatment over the phone. What I would say is in the past, we would have probably given you a couple of weeks of steroids to push it up. More likely now, we would give you a small dose of, a dose of one of the thrombopoietin derivatives.
Right.
And usually it's a tablet because they're more easily controlled, Avatrombopag or Avatrombopag.
So do you feel that is a better option to have, for me, a spinal block and not to have general anesthetic?
I can't say that.
Yes,
I think in terms of the surgery, both are equally effective. I have to say, if I was having a hip replacement, I'd want to be fast asleep. But it's very common now. It's very common now to do a lot of these surgeries under that sort of local, because your recovery is so much better. It's quicker. You feel much better post-surgery if you've had that. And you don't feel anything. You're just aware of all these people grinding around you, which I think I'd rather avoid. It's a bit like
I know this thing. I mean,
it's bad enough having a dentist forking around in your mouth when you're awake, and you can't avoid that. But in general, the decision about a general anaesthetic, it has to be one that the anaesthetist makes in seeing and assessing you as a person.
Right. Okay. Thank you. Yes. I mean, it's the seizure is what they worried about as well.
I mean, it's very hard to make a global recommendation on that, saying, oh yes, this is fine. It may be in some, it may not be in the others, and that depends on the sort of fine issues of the individual patient. But an epidural or a spinal block is perfectly fine for surgery and is very common, and they have a lot of experience of it. But a count of 65, 70 is, they'd feel more comfortable it was higher than most people would, to be honest.
I think this is what he said, the anaesthetist was saying on the day. So, okay, thank you for your explanation.
That's fine. I take that, but he should discuss it with your hematologist, so they plan together, saying, well, we're planning to do an operation on this day, check the platelet count. It would be nice to be a little bit safer and maybe get it up a little bit over.
Sure.
Steroids obviously have some risks of only slight increase of infection if you only had a short period. And that's why we've tended to use smaller doses of Avatrombopag, Eltrombopag, or whatever. But that's, again, a decision that your hematologist would make. But I hope they're able to do it shortly, because it is transformative, as you probably...
Yes. I had one done many years ago, already very good. So I hope this second one can be now done. But time, I have to be patient at the moment.
How long ago did you have your cerebral bleed? 2 2
2 years, 6 months.
Okay.
Yeah, but then last year I have a seizure, and
so do they think that was related to the ITP?
the damage, from the damage done. I had operation on my brain to clamp the veins, etc., and cut out, if you understand, cut out the bleed,
yes,
and then restitch, and then this seizure a result of the damage and a buildup of electric activity inside my brain head.
Yeah. Well, even at 2.5 years, you'll continue to see some improvement.
Yes.
So there's a likelihood that things will continue to improve.
Yeah, by talking it much better than it was before. So I keep doing my crossword.
Good. Keep your brain active. I mean, I say that, and I'm sorry to quiz you about your general medical problems in front of everybody. And in the spirit of openness, I would say that 3 years ago I had a cerebral bleed, and you wouldn't be aware of it now. I didn't have surgery, but I'm fine.
I was missing capillaries in my head.
You probably had what they call an arteriovenous malformation, which is
AVM, is it?
Yes, which isn't related to the ITP at all, and that's just something that happens. So
no, I'm born with this, they think.
Okay, yeah, certainly.
Yeah.
Thank you very much, mate. Thank you. Right, before we go to Bill and Susan, just want to do a quick plug because I noticed something in the chat and it's reminded me of it. Sue Havegood mentioned our conference is taking place in Manchester in May. So if you haven't got your tickets yet, please go onto our website. There's a link on our website. You can get your tickets. It's at Bridgewater Hall in Manchester, a fantastic venue. Refreshments are all arranged. Lunch is all arranged. So just book your tickets now before they all go. Right, that's the advert over. Bill, you're next, and then Susan.
Okay, a couple of hopefully quick questions, really. One is about repeat rituximab. I mean, I've had a rituximab treatment a year ago with my single-digit platelet levels and hospital admission, etc. It's been pretty good, but the question then is, well, at some point there'll be a deterioration, and what's wrong with having another go at rituximab if it's been done me quite well first time around? The general response I seem to get is, well, it's an immune compromising drug and maybe it's not a good idea, you need to move on to something more mainstream. So that was the first question. The other was a largely frivolous question, probably, is has anyone got the experience of papaya leaf as a complementary treatment for ITP? So those are the two questions.
Well, I'll do the serious one first. I mean, rituximab can be a very effective treatment, and if you had a very good response to it, there's a strong argument to be made for repeating it. And often what some have done is after 6 months or 12 months, just give a single dose to boost it. There are issues with high dose rituximab. Well, you see a lot of publications about the side effects of rituximab, and in particular, there's immune deficiency. Most of that work has come out from France in patients with the various arthritises that they treat with rituximab. Now, the doses that they use there are probably 3 times as high as the doses we use in ITP. Rather than the sort of 365 milligrams per meter squared, it's 1,000 milligrams per meter squared. So the doses are very high, and that's what's associated with immune deficiency. And it's in those where they've been repeating that on a regular basis that the side effects are most prominent. What we see in ITP is the doses that we use, and certainly a lot of us just use a much lower dose. We use 100 milligrams as a stat dose, and it seems, if you monitor the blood, it seems to work just as well in terms of knocking down the lymphocytes that are responsible for the antibody formation. It's if you monitor those, and it's at around 6 months when your immunity is coming back to normal, as often when the platelet count starts to fall again. And that's why it was postulated that you can repeat it. and it will have the good effects rather than the long-term, rather than the more severe effects of immune suppression. So although I wouldn't use it intensively, I mean, I wouldn't keep wanting to give, say, 4 dose infusions on a regular basis. Intermittent doses, I don't see there's an issue there. And so, yeah, we do use that. And certainly if you had a response for a long period and you're then repeating it, you're not actually abusing the immune system significantly. In terms of papaya leaf, I know of no evidence that any complementary therapies have any real effect. I don't mind people trying them because who knows whether these things are. I've never come across anything that I've convinced myself looks as if it works. But all I say to the patients is, as long as you tell me what you're taking, I don't mind, because some of the things you take actually can have a deleterious effect on the platelets. Papaya leaf, I don't know at all. That there was an old doyen of ITP, an American called Jim George, who used to come and talk at our convention on a regular basis for the first 10, 15 years until he retired. Some of you may have come across him. He got one of his students, research students, to trawl the literature extensively for anything that was related to complementary therapies, and couldn't convincingly find, I forget the figures, and I've not looked at it for ages, but of the several hundred case reports, he couldn't find anything that convinced him that there was an effect. So you take your money and you pays your money and you take your choice. I don't care what people try. I wouldn't say try this at the expense of regular therapy, but if you want to try things, I really don't mind. I mean, there is
some research evidence on papaya leaf that suggests it may have some positive effect.
Yeah, 2 or 3 anecdotal reports, but often when they're subject to more intensive stuff. But as I said, you may be lucky to be one of the odd people whose condition responds, and if it does, great.
Okay, Bill, thank you.
Yeah.
Right.
That's fine, thank you.
But what I did say that there's a series of things like vitamin D are very useful because they're associated with your immune function. Selenium levels, yeah, small dose of those may support your immune system. There's no convincing evidence they put the counts up, and there's quite a lot of anecdotal response on vitamin D and ITP. But what I know is they don't cause any harm. Indeed, I take vitamin D myself, particularly during the winter. It's also supposed to enhance your response to COVID if you're unfortunate enough to get it. So I tend to take it in the winter. I don't take it in the summer because I play golf with bare arms. So I get a full dose of sun-related vitamin D during the summer.
Okay, thank you, Bill. Next we go to Susan, and then there's a couple of questions in the chat. We'll go to them, and then to Sue Habgood, and then Rhonda. So Susan, you first.
Hello, I just wanted to say to the lady who they're looking to do spinal blocks. The trick seems to be, I've had thrombocytopenia for somewhere between 40 and 50 years. They don't really know how long. And when I've needed local anaesthetics for things like cesareans and that sort of thing, the trick seems to be to get your one specialist to talk to your haematologist.
Yes.
And they build a plan. So I was in the old days. My kids are now in their 30s and 40s, but certainly I had immunoglobulin transfusions before I had Caesars. And then more recently, I didn't do it. And I found out that can mean you can't have your spinal block because I'm completely cured, but I had major cancer and my platelets were modelling along about 40, so I wasn't seeing anybody for years. And then whether it's stress or whatever, but after they put me under a general anaesthetic, they suddenly found my platelets had bottomed out. So they couldn't give me a spinal block to help with pain after an op. So I didn't flag that I had a history of that sort of problem with prior operations.
And they didn't notice your platelet counts of 40?
No, well, mine had gone up a bit actually with the menopause. So that's the interesting thing about hormones, isn't it?
Yes.
Down in pregnancy, up with the menopause. I think they were probably up to about 60, but then they bottomed out.
They should have noticed. They should have noticed 60 as well. I mean, the important point you made at the beginning, as they should talk to the hematologist, because hematologists have a lot of experience of low platelet counts, whereas surgeons don't.
Yeah.
And they get very alarmed with counts that to us we don't even worry about.
Yeah.
Or we may tell them when they should worry. And this is time to do something rather than otherwise do a little bit of hand holding. And I think that's the important thing, is getting specialists to talk to each other. They tend to be a little bit siloed, but certainly most hematologists, particularly those who deal with ITP, and will deal with things. Through the association, we're currently looking at a booklet in ITP and pregnancy, which we think is crucial. Now, most major centres will have a hematologist associated with the obstetric department to handhold over patients with ITP and pregnancy. And again, we can say when to intervene, when not to intervene, when to feel relaxed. And it is important to chat to them about that. And often actually to have a surgeon, the same surgeon who always deals with those patients, so they get experience and a little bit of confidence in dealing with it too.
Thank you.
Okay.
I would also say to encourage people that I've hill walked and flown all my life without any ill effects. You know, as I say, if I was having symptoms, I would not do that. But while I haven't got symptoms, then I get on and enjoy my life.
Absolutely right. Absolutely right.
Best way. Right. Before we go to Sue Habgood, in the chat, Loredana, do you want to say your question there, or do you want me to read it out for you?
Hi. Yeah, can you read for me, please?
Yeah,
I'm not speak very well English, so.
Right. For the last 2 years, Loredana says she's been going to the emergency room with red spots on her body and platelets between 0 and 4. They gave her prednisolone and sent her home after 6 months. I came back. Then it came back. What should I do? There's no pill she can take that won't get me there. Still, every 6 months, it keeps going up and down. Recovery from steroids is not good. How long was you on steroids for? Forgive me asking.
Now I have from 12 days.
Okay.
And I need to take more 15 days.
Okay.
And
that's
all
not
the
very
time
long.
I take like 2
are you,
weeks.
from your name and an accent, are you actually in this country? Are you treated somewhere else?
Here in England from 3 years, and before in Romania. Where,
do you have a hematologist who looks after you?
Yes.
Because it's surprising to give you steroids for just 15 days. For a count of that level, we would normally give treatment for a little bit longer than that. I mean, we don't want to give treatment long term now. We try and restrict it to probably around 6 weeks maximum. But a count that drops to 4 or 6 and associated with bleeding can be quite alarming. And most people would want to add some more treatment in if there's not a good long-term response to an early dose of steroids. And we would probably want to give a full dose for a minimum of a fortnight, tailing off over another fortnight or 6 weeks tops, as I said. But if your count is running at that level, I would rather hope your hematologist would talk to you more about potential options and what can we do.
No, they tell me yesterday I have an appointment with my hematology and tell me from next week he wanna put me more tests for found something. Why? Because all the time on 6 months I go down. So I don't know how is the result.
Yes, well, I've just seen the other comment you made there, that you talk about recovery from steroids is not good for you mentally. I mean, we through the association, we've done reviews of side effects and on steroids, and one of the reasons why the last guidelines that we wrote restricted the dose of steroids because of the side effects. And big surveys amongst patients with steroids have shown that I think it's up to a third having had a first course high dose, so they will never ever touch steroids again. They'd rather swallow glass than take steroids. And it is And a lot of it's I mean, there are long-term side effects of infection and osteoporosis and diabetes, but it's often the mental side effects. You know, when you first take steroids, you can't sleep, you get up in the middle of the night to tidy up, you want to eat all the time, all those sort of things. But actually,
I want to cry all the time. Sorry.
The brain fog that you get with it, the fact that you suddenly start arguing with your husband or your wife if you're a man. I mean, this isn't sex related at all. But no, that's one of the reasons why I mean, there used to be a tendency to put people on steroids, and if they respond, leave them on it for ages, and the side effects are dreadful. And so we try and restrict that. You give a short, sharp course. If you don't have a good long-term response to steroids, you never will. There's no point in, I mean, you can use them for a short course to put a count up for a specific reason, but there is no value in continuing to go back thinking you're gonna see the same thing. Wasn't it Einstein who said one of the signs of madness is doing the same thing and expecting a different result? So yes, you need to talk to your hematologist about other options.
Okay, thank you very much.
Thank you very much. Right.
Well, Anthony has put something on in the chat about the links to the various treatments on our website. Thank you, Anthony.
I will put details of all the chat stuff on the YouTube channel, because Anthony's done a fantastic job actually highlighting lots of the bits we've been talking about, and pointers as well where to look for other information. Okay, Sue Hadgood.
I've just read her question. Is that the question, Sue?
No.
Okay.
Well, I suppose it could be, because I was interested to know what happens to your liver if it takes over getting rid of the spleen, getting rid of the platelets, because you haven't got a spleen anymore.
Shall I deal with that quickly?
Yeah, okay.
Well, the spleen is a small part of your immune system. It's less than a third. You have lots of, I mentioned earlier, you have immune function in your lungs and in your liver and in lymph nodes and things like that as well. So you can remove the spleen without having any long-term impact on your ability for immunity. The problems with removing the spleen is the spleen's a very good sort of sump for dealing with certain types of bacteria, and one of those is this pneumococcal bacteria, that it stops you developing sepsis, and that's one of the reasons why we give a pneumococcal vaccine before taking the spleen out. And indeed, the pneumonia vaccine, strep pneumonia vaccine, is used more widely now. So that's one of the reasons we do that. But you can actually, the rest of the body is very active immunologically anyway. The spleen isn't paramount, it's just one part of it. It's just that we know that the spleen is often the site of both antibody production and platelet destruction in a significant proportion of patients, probably up to a half of patients with ITP. So if you remove the spleen, you deal with the problem. But the issue is, if your immune system is working in such a way that you're removing platelets elsewhere in your liver or whatever, taking the spleen out makes no difference whatsoever. And that was why, I mean, pushing 20 years ago now, we pioneered the concept of putting a little radioactive label on platelets and seeing where they were taken up in patients with ITP. And if it was purely in the spleen, we know a splenectomy would work. If it was taken up elsewhere, splenectomy wouldn't work, and we didn't have to do the surgery.
Excellent.
To the degree now that very, very few people take spleens out, and it was very common in '79 when you had your surgery. I mean, I did that myself.
Yeah.
Patients in '79.
Yeah.
I mean, since '99, I wouldn't dream of it unless I had positive proof it was going to be effective. But
yeah.
It won't, as long as you had the pneumococcal at some stage and may periodically have a booster, and you probably were given steroids for a brief period afterwards. You don't need to take those long term, although the chief medical officer thinks you do, but you don't if you're not taking other immune suppressive therapies.
Yeah.
So
great.
anyway, so that's fine. Okay, so what was your question, actually? Just a little diversion.
Well, that's great. Thank you for explaining all that. Yeah, I've had my spleen out since 1979, and I'm doing fine most of the time, actually. But recently in this year, I had a downward turn in my platelet count, got put on steroids, 2 lots, and eventually it came back up. But there was a talk of me going on Avatrombopag, but I haven't had to, luckily. I just wondered as well if the research on the gut biome, or whether that's something that that the scientists are looking at, with how that affects your possible immune system. But that's just a very broad question.
Yeah, I mean, it's a very interesting question, and like several of the answers I've given this evening, we don't really know. The likelihood is it probably has some impact because there's a lot of immunity going on in the gut. I mean, your gut has lots of sort of lymphoid follicles throughout because it helps protect you from infection in what comes in. We did fund a study in Cambridge a few years ago now, probably 10 years ago, looking at the gut. This was before the term gut biome was actually introduced. Yeah. And we found no real association with diets and ITP. And this was a very good gastroenterologist who had a particular interest in that. But it is something that's rearing its head again now, and people think about it because the techniques of looking at it are more sophisticated. There is no answer to you, but the likelihood is that it may well have some effect, because all the immune system has some effect, and we know that the gut immune system is very much educated by what it's subjected to in the gut. So logically, the likelihood is there must be some effect. But the answer at the moment is we don't know. But it is something that people
there's some work, Adrian, going on at University College.
Yes.
Nikki Cooper's team, Camilla from Nikki Cooper's team.
Yes.
Is doing some work on it.
Yeah.
And she actually did an article on this very subject that was in, I believe it was in our December Platelet.
I'll have a look.
Yeah. It's worth a look. Worth a look.
Yeah.
Can I just add something, Adrian?
Sure.
I couldn't, I mean, I've been on Romi for several years, but then suddenly my platelets started to really drop, going from an average between 40, 50 down to 26. Now, first time I tried Ava, my gut was not in a good state. I have really bad IBS and so on. But over the last few months, I've been taking a really, really good prebiotic. And this time round that I've tried Ava, I'm tolerating it really well. So good. I think maybe, whilst we don't know if the gut, I think there's a mixed opinion about whether the gut biome influences the platelets themselves. But certainly from side effects point of view, I made real progress with Ava.
Yeah, good, excellent.
Good stuff.
I've got a very good consultant at Musgrove at the moment where I go, and I feel I can talk to him about most things. So I'm really pleased about that. And if I have any worries or anything later on, I'll have a chat with him.
Yeah, good, excellent.
Thank you.
Rhonda.
Yes, thank you. Just a few quick things, because I know we're running out of time here, or we have run out of time. Just to say that I did have a splenectomy in 2000, and they wanted my platelet count to be 80. I actually had the operation when my platelet count was 8. So it is possible that they will do an operation when you've got a very low platelet count, but of course there are risks, which were all explained to me. As far as whether diet or anything helps you, the advice that we always give, and I know that Adrian's covered some of this, but I will just say it again from a patient's point of view, that generally looking after yourself, with all of the stuff that the Daily Mail regularly comes out with, this is the way to lead a healthy life. Have a good diet, exercise, get plenty of sleep, hydrate yourself, keep yourself as happy as you possibly can by interacting with people, by helping people, and by doing all the sorts of things that are really sensible. Sounds terribly boring, I know, but it really does help. And I think that anybody who's got any problem at all, health-wise or mental health-wise, physical health-wise, would be wise to really look at how they're living their life and how they can tweak it to make themselves happier, better, and everything else. And really get on and enjoy your life. So every day, please do something for at least 10 minutes that you really love to do. And then every person is absolutely different. So we always say this in ITP, all patients react differently to different things. You are unique. Your medical team are unique to you as well. And you need to work with them as much as possible to get the confidence that you need to carry on. With the gut biome and taking anything, you have to be really careful, because I wanted to take some probiotics or whatever they are. And I spoke to my pharmacist. He was going to get them for me, but he said, just a minute, I'm going to find out from the manufacturer if it is good for you to have these or not. And the manufacturer came back and said, no, I should not have these things because I had had a splenectomy and so on, and the other conditions that I have were not suitable. So you do really need to find out if you are suitable to take anything that you think you'd like. So I just wish everybody all the best, and I hope that you stay well. Thank you.
Thank you, Rhonda.
I'll just make a couple of points about things that Rhonda said. I mean, when she had a surgery with a count of 8, as soon as you clamp off the artery going into the spleen, platelets stop being destroyed. And so they're immediately effective. And so the surgeon will get in quite quickly. We'll often give a slug of platelets at the time of surgery just to cover that initial skin incision and operation. But as soon as the clamp's put on, the platelet count goes up, so it's safe after that. But of course, I said we do very few splenectomies these days. The other point I would make about some of these supplements that people take, they actually have small dose of steroids in them, often the anabolic steroids. Of course, this is what athletes always claim when they test positive for something. It was the supplement. It was nothing to do with me, Gov, that sort of thing. But it is true that some of the supplements do have small dose of steroids in that may be the component that's giving an effect on your platelet response rather than the supplement per se. But these things have lots of things in them. They're not tested in the way that drugs are by companies through going through rigorous testing protocols. You know, anyone can find something and put it on the market, as long as they don't make major claims. Well, you can probably sell it on the internet anyway.
It's true. Thank you very much, Adrian. Right, very, very last question. Bernard's been waiting ages. Bernard, you're on mute. Well done. You've done it. Go ahead, sir.
Right. I'll keep it quick. I was going to ask yet another question about surgery, but I think I'll save that for next time. But I did want to say on the gut microbiome, Nikki's project is actually in the Imperial Group. It's based at the Hammersmith Hospital. I'm on the steering committee for the study that they are setting up on the relationship between the gut microbiome and ITP. At the moment, we're still working on the way in which patients would be able to record their diet in a way that would be analyzable and useful in terms of getting information about what's affecting the gut microbiome, and also the regularity and type of blood testing that they would need to do in order to relate what's going on in the gut microbiome. But I think they're probably still recruiting patients and controls, and they have a preference if you are going to be a patient in this study for controls who are either in your family or your household, because there is likely to be a similarity in your gut microbiomes. Now, I've got no idea what the time scale is for this, A, to start operating, and B, to start producing results that can be analyzable. But I think it's going to be important for the future. So anybody who wants to make what I hope would be a painless contribution could at least contact Nikki Cooper at the Hammersmith Hospital and ask, Mervyn, don't you have details about it?
I do, because I believe, listening to you now, I believe we met at Hammersmith.
We did.
Back in
and
September.
subsequently, we've had I've had 2 meetings of the Gut Microbiome Steering Committee.
Yeah, that's right.
And it's really important in order to get a scientific study underway, rather than a lot of conjecture based on he said, she said, he denied, she denied. And I think we're working towards it, but you know, there's a long way to go.
There's a huge long way to go. Yeah.
I would just add there that Nikki was the clinician who was involved in the gut study that we did 10 years ago with Addenbrooke's. So it was Imperial and Addenbrooke's, and she learned a lot of the lessons from the problems with that and the difficulties in measuring it, which is what she's now put into developing the study now. And I think it's an excellent thing to do. The trouble is finding the right patients and the right controls and studying them and how long you do it for and what you actually measure. And one of the things she'll be doing will be tucking material away so that if in 6 months down the line we think, we should have measured that, you've still got serum stored that you can go back and look at. No, I think it's an important study. It's an important study.
Okay, and I'll ask my question at a future meeting, but because I've got a complicated surgery question.
If it's more acute, you can always drop a line to Mervyn, who will pass it on to one of the medical advisors, and we can comment on it.
Okay, thanks.
Okay, thank you, everyone. I think we call it a night now. It's been an excellent meeting. So many varied questions as well. And Adrian, how you kept up with it all, I don't know. But thank you, everyone. Thanks for joining us. Next meeting we've got is the Scotland meeting on the 5th of February. I believe Anthony put it all in the chat. But 5th of February with Dr. Catherine Bagger. And then on the 12th of February, we've got the Ireland meeting with Dr. Gerard Crotty. But as I said before, don't forget our conference in May. Please book tickets. You're all welcome. And lunch is provided. Thank you, everyone. Take care.
Thank you. Delighted to meet you all. Pleased to be involved. And thanks all for coming home. We had a super mixture in mid-30s, which is great.